Is the link shared with the other attendees as well in the other groups? Hi, good evening. I think we can start as others are joining. So this is really interesting this year because people are have choices of plenty and some have choices of little. Because those who have done well exceptionally would be probably be getting all the branches, and those who intend to improve upon their rank and want to think of giving their branch of choice a second chance, they are a bit confused because they may be getting an alternative branch and maybe more inclined to skip it for once and then maybe take a call again. So how do you, before I take specifically as other people join in how to choose a seat in cardiology, I'm also going to touch upon how to choose a branch. Whenever you're choosing a branch in the current scenario, these are the super 21 points that I say. This is something that I've been teaching and discussing with my students ever since their undergraduate days when they want to do a PG. And believe me, these are not the exhaustive list. This can be more than 21, but these are some of the aspects, because when I talk to people, they say, "Maine to ye only one branch. Yes, I had only thought of interest, or I had only thought of something else. Whether I can fund it, whether I can live in periphery or not, or whether the branch is saturated or not." This is not how you choose a branch. Branch choosing in a career option counseling is usually a multifaceted thing. Of course, one and foremost important thing is the interest that you have in the branch, and that's what number one. So I got a call from one of the students who had cleared and got good rank, but I don't want to, I will not be sharing his name, but he said, "Sir, I have multiple exhaustosis. And I've been told that radiation exposure in cardiology would give me a risk of developing malignancy. Do you think that I should still take cardiology?" I said, "What do you like?" He said, "I just like cardiology. I don't like anything else." So I said, cardiology beyond radiation is still a huge branch. And even the risk that is involved is, there have been people who, with radiation, who have developed with a hale and hearty situation, ended up with a brain tumor. But that need not always be associated with it. It may be something else. Though people say that the left temporal tumors are more common than this right one because of the nearness to the lead. But there are a lot of devices, shields, protective mechanisms that people can wear and shield themselves from radiation. So I think I could convince and talk to him that what he should pursue is his interest, because I usually say it's like a marriage, probably even much tighter than marriage, because you can divorce your married life, but it's very difficult to divorce your career. You are usually bound to the career. You can actually do a sub ramifications of the career in the branch itself. You may do cardiology and end up doing, say, electrophysiology, but you would always be looking at various aspects of it before you make a choice. And because of that reason, I think we should know and take a core, an aware decision, rather than, some of these may be important for you, some of these may be not important. But what is most important, that if you're not interested in a branch and everything else falls into place, you are just pushing yourself into that branch with half a heart, and you may not feel happy at the end of the day. And when you're not happy doing something, the rest of the things are going to suffer. So it's like you take a branch because you have interest in the branch. I gave up civil services when I was allotted the cadre, when I cleared civil services when I was doing my MBBS. And at that time, when I had the choice whether to join IAS, IPS, or the civil services, I opted not to join it simply because I wanted to do cardiology. So my cardiology was a dream that I had pursued even when I was a child. And when I thought of as that when I will turn 50 or 60, will I be happy being a civil servant, or will I be happy being a cardiologist? And then one of the fine days, sitting alone talking to myself, I realized that my happiness lies in doing cardiology, and I didn't join the services. So I think it's the interest, whether you are going to be sticking around with the same profession for some 20, 30 years, or at least a couple of decades to come. So that's what you like, and liking is not something that you can quantify by doing a test. Of course, there are various aptitude tests. We had ourselves designed a couple of aptitude tests to find out whether you like a surgical branch versus a non-surgical branch. That's a separate long itself presentation. But my whole idea of talking today was to discuss about cardiology rather than to choose branch between others. But I thought I'll touch these 21 important points that you should consider, especially guys who are getting seats in all the categories, or the guys who are or girls who are inclined to one branch but may not get the branch of their choice. So it's like either I'll get this or not get this, and whether I'm going to stick with it and take a second shot or not. So interest is the first and foremost and most important choice that one has to take about, and the rest of the things will fall into place. Now, second point is acumen. You may be interested in doing microscopic surgeries, say neurology or even cardiology, you wearing a microscope, but do you have acumen for surgery? What do you mean by acumen? If somebody has got, say, I know a couple of guys who had early onset of Parkinsonism in family, and he also had tremors when he entered residency. Now, if you have tremors and you want to be a surgeon at the age of 35, it's going to be tough to some extent. So from that perspective, it might be very important to know whether how confident and comfortable you are in staying around with the acumen. Again, another thing is like cardiology, though, has an intervention, but the branch like neurology would require you to be slightly of a deductive analysis or what you call a mathematical analysis kind of a guy. That holds true in all branches of medicine, but it's more so in neurology. You'll have to have that if 1 and 2 are present, then the next deduction has to be 3. So, for example, site of lesion in a case of paraplegia, you look at the various findings and try to localize where is the lesion. Once you localize it in spinal cord, you localize it in the vertebra, how the vertebra are different from the spinal cord levels, and then try to look whether it's extramedullary, medullary, etc., etc. Same way, sometimes in cardiology also, you may have to do that analytical thinking. If you have that analytical thinking, these are the branches that you are likely not only to excel because of your interest, but also your ability of being deductive, analytical person in thinking is likely to excel. If you are a guy who's just going to go in, see, and come out, then probably more of a surgical or the interventional orientation branches are more likely to help you out. For example, upper GI scopy, lower GI scopy is more of a surgical skill. So are you more skill-based guy, or are you more analytical, deductive analysis kind of a guy? Can also help you to do whether you have an acumen for doing those procedures or choosing that branch. Also, now a lot of people talk about where you want to settle down. For example, previously it was said that for interventional cardiology, you cannot settle down but in a big city. But now that's no more true. A lot of cath labs are mushrooming across the state, and a lot of district places do have cath labs. And that's why this place of settlement would not be that much of a deterrent when you're choosing cardiology. You need not always be sticking around. Somebody wants to be in his village hometown, which is not a metro per se. You can still choose cardiology and settle down in periphery. Same may be the case for other branches, but if you're choosing a super specialty like electrophysiology in cardiology, then settling down in periphery may be not a very good idea, because it might be more the number of patients that you end up with doing electrophysiology are more likely to end up in tertiary care centers like a metro or a big city. Also, a lot of times you also need to look at to how supportive or how conducive the branch that you choose. Ultimately, man is a social animal. How supportive your family is going to be for a branch that you end up choosing, whether it's hectic or not hectic, whether your wife, if there have been people, I mean, the surgeon, a cardiothoracic surgeon and a cardiologist are a spouse, and then it's like a bypass or angioplasty all gets into family. So those are comfortably deductive, analytical, apart, family supportive structure that you can think of. But it's one of the factor that you can consider. But you can have a non-medical wife who can still be as supportive, then maybe even have a same branch a spouse and may not be supportive. But at least these are some of the other points that I thought you should consider. Teaching posts and vacancies. It should be vacancies, not vaccines. Sorry for the typo. So teaching post and vacancy, when you look at the lot of medical colleges are coming up, including those in the private sector. And there are a lot of posts that may be available. Teaching posts in government colleges are going to be restrictive because of the expanding model of the public-private partnership. A lot of private colleges are going to come up. And now with the increasing DNB seats also, there might be some teaching posts emerging in the private sector as well. And you might have to, depending on your state or city, you might have to explore that. Because I remember in one of the state where there was a bond and students were supposed to go to a tertiary care hospital to get their bond fulfilled, but those places did not have a cath lab. And that's why those cardiology passed out guys, they had to approach court. And the state court then passed an order that these guys cannot be posted, but in the places where the cath labs are available for serving their bonds. So a lot of those local factors for teaching post vacancies will come into play when you're choosing a branch, and things may change very dynamically with the kind of emerging of new colleges, super specialty also being taught of, like a medical college which is now having a postgraduate course. In 3 years, it's very likely that one of them may be inclined to develop a DM course, and then you can have a seat coming up there and maybe have a vacancy there. extent of emergency. So if you choose a branch like cardiology, very likely that you'll be probably in initial phase unless you work as a team or on rotation basis, working 24/7, 365 in initial hours. But if you're choosing, say, a branch like a rheumatology or maybe say neurology, the extent of emergency and the kind of work that you might have to do and rush around is less likely in those branches. I'm not saying there are no neurologic emergencies or rheumatology emergencies, but compare it with, say, cardiology or say acute GI bleeds that you may get in gastro, they might be few, or say in the endocrine emergencies. Again, these can be often be managed quickly. You can, even if you have to attend it on a phone call or visit personally, you just have to go, and the rest of the things are done by registrar. In cardiology, if you end up with an acute MI, you have to do everything from a scratch to the end. So incision to line access to stabilizing a cardiogenic shock, you have it. What are the partnership prospects? Partnership prospects in terms of whether you can develop a team, whether you can have juniors under you, whether you and your colleague who are doing residency together and in the same place and come from the place where you want to settle down, or do you have a scope for developing, say, a partnership prospect? So a lot of people do that now. It's emerging as the next line of entrepreneurship in medical profession. My part of the world, like in my state, group practice is a big thing. Like I belong to a group. There are a lot of other groups that practice accordingly. And there are now group practices emerging even in neurology, in gastrology, in our part of the world, and in Gujarat. And I think these are the future to see, because everybody now wants to do a work-life balance, as they say. And for that, the partnership prospects, I think, are going to be just more as you go on to explore as in terms of future. Financial expectation. There are people who say it doesn't matter to me whether I make 2 lakhs or 5 lakhs or say 5 lakhs or 10 lakhs. So what kind of expected? There will be branches where you just do consultation based, limited hour of procedures. And there are other branches where you have more intervention, where you can actually have a bigger remuneration coming in. Also, you can look at in terms of what is the guarantee money that has been given to some super specialist who visited recently passed out in your city and got a guarantee package from a hospital or from a private setup, or how it's faring. And then you try to match out what is your expectation and what you're looking at. Other thing that I feel is the future is the research and innovation, because I think from here we have to move to a higher level when there'll be a lot of DM cardiologists or DM neurologists. Are the guys who are going to stick out amongst the rest are the guys who are going to innovate, guys who are going to publish more, guys who are going to be heard more, who have more acumen for innovation. That's going to make you clear winner in the other branches. So there are certain branches which have stagnation as far as innovation is concerned. But like, for example, I say endocrinology. There is a vast, tremendous spectrum of new therapies emerging on the horizon. This more likely to come in endocrinology than you can expect, say, in neurology, for that matter, because you have a lot of new therapies or new modalities, say managing of diabetes. Now you have GLP-1, now you have GIP analogs coming into the market. So SGLT2s were there and LGLT2 are expanding. And then you are part of various clinical trials, research, innovation, research publication, consensus statements. Do they matter to you? Each point may not be equally important. For example, somebody may weigh 90% to the interest and rest of the 20 points only 10%, or somebody may say I have equivocal interest in all, so I would give 10% to say each of them and then try to analyze as to what falls into place. Other important aspect is dependency on referrals. Now I see this dwindling again with the development of awareness amongst the people. So patient who's got a movement disorder is very likely directly, or epilepsy is very likely to directly approach a neurologist, rather than you end up with a GP and then a physician and then a neurologist. With the availability of increasing number of super specialists, then the availability and the awareness amongst people, as well as the corporate market trying to push into the super specialty segment, the referral dependency is mitigated to huge extent now. But again, it stays very much in interventional branches, to some extent in, say, cardiology. But again, if you look at in terms of competition, every physician is a diabetologist. Every physician is competing with you as an endocrinologist. So there is a give and take, an advantage and disadvantage between the two. The referral dependency is something that you're not very keen. You want your own patients to develop. I think the best strategy is to develop your own rapport brand and your own outpatient services. If you develop outpatient services, that's how you directly try to bypass the referral dependency. Of course, professional hazards like infections or radiations, like infectious disease specialists, were most sought after in the COVID era. But ask these guys how scared or not scared they were in the COVID pandemic as it was emerging. Do you or you don't intend to be motivated enough to be working in those environments? If not, for example, radiation may be the other thing in cardiology. That's the part of life. I say that radiation that you have to entail from the cath lab is something that you have to learn to live with, and also learn to how to cut it down. Again, the medical legal litigation risk is though increasing all across in all the professions, but there are some branches which IMA, Indian Medical Association, identifies to be more prone than the others, and you can go through that. The branches with there is a surgery involved, intervention involved, are more likely to be litigant as compared to branches say like endocrinology, where there is only outpatient consultation in the routine setup, as the proportion of outpatient management is much more as compared to, say, interventional branches where you have to hospitalize and operate upon the patient. Also, job prospects in terms of not only your country or your state or city, you might be inclined, if you have one, to look at prospects abroad. Especially, a lot of people are more keen to go to Middle East, say Dubai, etc. And some people are also looking to do super specialty and then move abroad to countries to get a fellowship. And you will have to explore what kind of fellowships are available and can be undertaken in the branch that you're choosing. Also, how further you need to do subspecialty rather super specialization. For example, in cardiology, they say if you're doing DM, probably now in the next decade, it will be like either like it's in US, either you're a structural guy who's doing only TAVI and mitral clips, or you're an EP guy just doing electrophysiology, or you're a pediatric cardiology guy, which is a separate fellowship, or you're just a hardcore interventional coronary guy. So it's unlike when we were doing residency, we were like jack of all or master of all, whatever you want to call it. Now you will have to master only one subspecialty in the decades to come. How is the family support system when you're doing a super specialty and then intending to do a sub super specialty? Is your family, in terms of as a support system, financially or socially, is well prepared to support you for the next 3 or 6 years? Is something also that you might have to take as a personalized decision. Interactive nature in branches where you need to interact more, talk more, dig the history out properly. This is very important in certain branches. For example, say neurology, where history is such an important aspect of reaching a diagnosis. But say in certain branches where all you need to look at is the sugar report, CGMs, HbA1c, and those reports, even patient does not expect much of inquisitiveness from your end, and patient is pretty happy if you can keep his sugar under check. So how interactive or how introvert or extrovert you per se are is something else that you can look into and try to explore. Also, what are your goals in life? Financial, social, otherwise, those goals, how quickly you want to attain. If there are certain goals which are too big to attain through a branch that you are looking at, and where there is a lot of incubation period for transformation to the next level, then you might have to think about a branch which has a shorter incubation period, say rheumatology, say endocrinology, where the incubation period is much shorter to rise to the next level as compared to branches where there might be intervention. As I said, physical limitation. If you have a physical deformity or a limitation in terms of exercising, keeping awake, ability to stand for long hours, you might have to think of branches where these are more the branches that may require long hours of standing, say in cath labs or ICU, whether you can do that or not. Hours of working, again, will depend from place to place. If you're into government service, it doesn't matter. But if you're into a private practice, how often do you want to work? Whether you want to work night hours or not, you want to work, sorry, weekends or not, those branches do matter. And work versus life, or work is life. There are work ethics and work culture. I'm sorry, that may differ. And in what's your ethic onto it is also something that you need to do. So, sorry. So these are the 21, what I call super 21, before you choose a branch amongst all the branches that you're getting. So this was not the topic at all. This was just to build up a point of perspective when you're choosing a branch. Analyze it for yourself. What is for me may be different for you. And this would differ from person to person. Now, let's go to the whole point of cardiology seat selection. So I hope I motivated a few more guys to probably think about ponder over cardiology. And if you're choosing a seat, these are the points that I feel. And again, I'm saying this is not exhaustive and this is not complete. There might be some more perspectives about it, and which can be discussed individually on case-to-case basis. But we need to take a seat which probably will be determined by these important factors. And as I say, first and foremost, I very strongly feel if you intend to settle down in a place or a state or a city, I think it's good to invest that in the same state or city to build, number one, reputation, second, rapport with the patients and your peer and the colleagues and the referrals, and three, the comfort that you generate in the simultaneous social circle, say friends from school, friends from college, your inter-branch referral patients, your patients that you've done your residency, say in MD, would still be hanging around and coming in touch with you if you're doing it again in the same state. So I strongly feel that being in touch in that same environment and knowing the reality, what's happening, where you intend to settle down, is also an important factor. But if you think that factor is superseded by the reputation of that institute, if your institute is not such a great institute, you think that you're not going to get the other 11 points, then you may think of moving out. So reputation per se of an institute, say All India Institute at Delhi, absolutely everybody has a very high regards for it and a reputation for it. And then the program itself will give you a good benchmark for labeling yourself. It's like the IIT of an engineering. So if you have a good reputed seat to come in, and there is a huge difference between the two, that the other choice that you're taking off, then go for the repute one that exists in the market. But I feel that the distinction between the repute and its implication into practice is dwindling as the number of seats are expanding. Other important thing is something exercise that everybody should do. What are the number of beds or number of indoor patients? Because you can't look at the number of indoor patients done. Not every institute is mentioning that on their website. A lot of institutes do, but at least everybody will be able to make out what is the total number of beds and what are the number of student seats and the ratio to it. So normally, if the beds are fewer, that means the turnaround time will be quicker, but the number of patients treated may be less. If you can get actually the number of patients hospitalized to number of seats, is the best thing, but it may not be easily available. But look at some institute which has got, say, 1,200 beds versus, say, 20 beds, and the number of seats. So you have 1 seat versus 10 seats. You will have to get that ratio. The more likelihood, not only it will tell you about the work burden, but more importantly, it will tell you the work you will get as a residency in a branch like cardiology, where you looking forward to do more interventional stuff. Also, it's important because when you enter practice, you're very likely to be handling acute emergencies. And it's so important that you learn at least doing primary PCIs. So ideally, that institute should be a PAMI-enabled center, which means if a patient walks in at the middle of the night, does that center provide? It may not be that every patient gets a primary PCI. Some may be getting licensed, but does a primary PCI end up being done in that institute on a walk-in window period, as you've learned from your textbook? So it's important because how you treat a stable type A lesion is very different from how you treat a primary PCI. So even if you may not be doing it in residency, you need to get in nick of, realizing how that primary PCI is to be handled, the protocols of it, the whole training around the primary PCI comes from that. Also, does the center have a subspecialty? For example, like All India Institute, I'm giving name because that's that seat doesn't come under this, and I'm not biasing you against any individual institute. But say, for example, All India Institute has a dedicated interventional radiology. So that's an advantage and a disadvantage. By interventional radiology, you may not get training, and a lot of EVARs, etc., are done by them. and you have a dedicated EP unit there. So EP is a separate unit, but you may get a rotation and exposure there by getting rotated into that. So if there is a dedicated, so there might be institute where there may not be a dedicated subspecialty unit, and hence the exposure may be generalized, not subspecialized. And hence, if you intend to develop a subspecialty program in your career, then probably that exposure may not be good enough to give you neck of kind of training that may be inculcated or required for that subspecialty. Also look at the reputation of that institute as well as of the faculty. So a lot of institute it may be an institute may have change in faculty, or a faculty may have moved to some other institute, or maybe the faculty is due to retire. Is the senior most faculty may be a big shot across India, but the reputation of institute may not be matching his standards, or maybe institute has got a big reputation, but the faculty is not matching. So you'll have to find both, because ultimately it's the person who's going to train you and teach you. You'll have to match both the place which gives you both the repute of the institute and a faculty of repute as well, and they are supposed to give you the results also. So you results in terms of not only training but also passing. So a lot of people talk about what kind of results do you get, and a lot of people choose DM over DNB for this reason in past. Now the DNB results have also improved drastically, but previously people used to prefer DM over DNB simply because it was assured that you'll pass, and DNB it was like pretty not so much sure, and the results used to be low. But now of late, when you see post even the COVID era, the results are pretty much matching in both the standards. That's one good thing that has happened. So that distinction would have to be matched against the faculty reputation, results of the faculty, and the institute's reputation. Also, there is a lot of discussion and debate about bond amount and duration. There was an assumption that some institutes have till couple of years back, it was different for various states, and it was very different for different institutes also within a state. So you'll have to individually look, and there was an Excel sheet which was there in one of the Telegram group that I had seen across last year, where they had compared all institutes with the bond and the duration. You can also get hold of it, but I think it's changing. There was a proposal by Ministry of Health, I believe, or maybe through a if I'm wrong, there was a proposal actually mooted by one or the other places that it should be made uniform. So all institutes should have same amount of bond and duration. I'm not sure how it's going to turn up, but it was proposed, and I believe it's going to happen in near future. But you need to, as of now, go through it and see for yourself if you can actually serve the bond and the duration for which the amount is mentioned in individual institution. Also, you need to look at the number of intervention. This you can easily get from the CSI NIC website. So CSI Cardiological Society of India has got a National Interventional Council meeting, which is done annually. And it is mandatory for every teaching institute to be participative. And every institute reports their number of procedures done every year in this meeting. So all big institutes should be reporting their data. But again, people talk about how genuine that data is or not. But at least you will get a good fair amount of idea as to what number of procedures or what kind of procedure the institute is giving. You can search on the NIC website, CSI NIC website, and then they will be reporting what are the institutes doing top 10 cases or top 10 numbers across for the overall interventions done across India. A lot of people actually ask for hands-on experience. Now, this may not be always be in residency. Some other places have 1 year extension SRship, and then in that, a lot of local students do get a lot of work. So again, you try to find out immediately, ideally, as our other faculties have shared, ask somebody who's first year or second year or third year that you know in that institute, ask how much hands-on you're getting for the intervention. Also ask how is the first year residency, what do you learn in second and third year, and immediately you interview the immediate seniors. Ideally, you should interview the first years and also the guy who's just passed out. Those two guys will give you a good idea as to how the things have been. Though this again is a dynamic structure, you may have new APs coming, new faculty change, administrative reforms happening in the institute. So these places may be a dynamic structure, but at least it will give you a good idea how the things have been in past. Also, whether that institute publishes well and is a research-oriented institute, because now it's mandatory to have 2 publications before you become an assistant professor. So whether that institute, when you join, whether the seat that you take will get you 2 publications by the time you pass out for becoming an assistant professor, because it's mandatory to have 2 publications as per the NMC and MCI guideline, that to become an assistant professor, you may have to have 2 or original research articles in your name. So whether you can achieve that in that institute, wherever the seat you're trying to take to get 2 papers, also it will not only be of value in terms of getting that post, but also it will give a different niche of inclination that you will have for development of career as a researcher in the branch of cardiology. And also try to look at the academic program. Do they teach? Are there rounds? Are they teaching in the rounds, or there are morning academic sessions? Are there faculties who are academically inclined? Are there separate teaching programs? Is there a designated program, how it is done? Or is it only during the exams that couple of classes are done? So that academic program also you should be aware. So these are the 12 important points that I thought I should be sharing with you. I think if there are more points that you have, I can ask you. But these are something about your practice. Remember that when you enter, this is not about just practice, but even when you enter your residency, you must have your degree registration with when you join, with 3-year completion certificate of your PG. Look at the transcript of the PG already taken, because you should not be rushing after finishing your DM to get your medical transcript of MD. Also, you need to update your CV with the publication and thesis. Try to get your original certificates if they are deposited at the place where you're doing MD. Also, if there is a bonded certificate which can be extended, you'll have to do that. Also, even if you're a resident, you will have to take the professional indemnity. And a lot of times it is recommended that Indian Medical Association's professional indemnity does cover you pretty well, at least in residency. In practice, you may have to take personal professional indemnity. You must be preferably be member of a national association so that it helps you out. There are some social security scheme, life insurances. You should cover financially yourself and your family, cover yourself medically. A lot of institutes provide you mediclaim, medical cover when you're resident. And there is a hospital cash policy. That is also something that we can think of. When you're sick, you get paid for not working those days. But that's, I don't think, applicable in residency. That's more applicable when you're into practice. So these are some of the other things before you start practice that one should know. I think I should end my talk here, and I will be seeing if there are any questions that can be taken in the chat box, or you can pin me and text me personally in WhatsApp, and I will be glad to answer you. So in the chat box, if there are any questions, I can see. So right now, I think there are no questions per se, and we can end the session. And you all have my number. You can text me in the WhatsApp group or text me personally, and I'll be glad to help you out in giving you a guidance in which whatever way I can, in helping you to make your decision rather than be guided by my views. Thank you very much. Take care. Best wishes for taking up a seat. Congratulations again to all the successful candidates. And for those who missed out, my best wishes. Don't lose your heart. It's just one matter of one more attempt. Thank you very much. Good night. Take care.